Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullah. I am welcoming you all a short lecture on topic from gastroenterology. This is very important for exam in post-graduation exam of gastroenterology. Come as a short note in a very written format, that is recurrent pyogenic cholangitis. This recurrent pyogenic cholangitis, I will describe recurrent pyogenic cholangitis from Sleisenger and some hand note from various sources. So first, come to the definition of recurrent pyogenic cholangitis. Here I already underlined definition. This is recurrent bacterial cholangitis, intrahepatic pigment stone and biliary strictures. These three, when they leading to chronic liver disease and cholangiocarcinoma, these are the characteristics of the recurrent pyogenic cholangitis. So we can say that recurrent pyogenic cholangitis is characterized by recurrent bacterial cholangitis. The bacterial cholangitis or cholangitis is a recurrently occurred, intrahepatic pigment stones formed, and after biliary strictures may develop, and all these things may leading to chronic liver disease and cholangiocarcinoma. There are a few other names. The first definition we have completed. Now there are some other names of this recurrent pyogenic cholangitis, very important. Someone says Hong Kong disease. This is very much important. Hong Kong disease, oriental cholangiohepatitis, then biliary obstruction syndrome of the Chinese, hepatolithiasis. These four other synonyms are present for recurrent pyogenic cholangitis. Now come the point epidemiology. Epidemiology, most common in Southeast Asia, men, women equally affected. The lower socioeconomic status persons are mostly affected. And if there is history of infection with Clonorchis sinensis or Ascaris lumbricoides or Opisthochus species, there is a more chance. But here is the another point from the hand note. I have taken a screenshot and added here this etiology and pathogenesis. I add this short screenshot. I found it more comfortable to read from the book. Etiology and pathogenesis. Here, the biliary tract infection is one of the cause. Low protein diet low in saturated fat, abnormal motor activity of sphincter of OD, Clonorchis sinensis survive, and low socioeconomic status and malnutrition. So if we have time to mention etiology in our short note, we can just give the headings like biliary tract infection, like Clonorchis sinensis, Opisthochus sinensis, or Clonorchis sinensis, or Ascaris lumbricoides, biliary tract infection, low protein diet. Here the explanation why low protein diet is a risk factor. Decreased biliary level of glucose inhibitor and beta glucuronidase, deconjugated bilirubin into conjugated bilirubin, calcium. So clumsy. I think low protein diet, low in saturated fat. So low in saturated fat means high in carbohydrate. So decrease cholecystokinase secretion, decrease gallbladder contractility. So stone formation. Abnormal motor activity of sphincter of OD due to papillitis. Clonorchis sinensis survive decay in bile duct. And low socioeconomic status and malnutrition. So already I have covered definition, other name, epidemiology, etiology and pathogenesis. So don't require to read this paragraph. Now come into pathology. Pathology means characteristics findings will be showed stricture and dilatation of intra and extrahepatic bile duct. So the all bile duct interdiaphragmatic, there will be stricture and dilatation. Left duct is more involved. Atrophy of the left lobe or left lateral segment of the liver site at where cholangiocarcinoma develops. So cholangiocarcinoma more common in left lobe. Calcium biturbinate stone, cholesterol stone also found. Over particularly Clonorchis sinensis found in stone. So pathologically we found the stricture and dilatation of the interhepatic bile duct, atrophy of the left lobe, and also there will be stone. Clinical features commonly will found Charcot triad, which comprises of right upper quadrant pain, fever, and jaundice. In the book, there is a mention pancreatitis, abdominal pain, and in this handnote we also came to know ascending cholangitis. So on examination, abdominal tenderness will be common. Hepatomegaly may be found in 20% case. Palpable gallbladder. Due to emphysematous cholestasis, there will be palpable gallbladder. So next investigation. I instead of the book, I keep this handnote. I think it's more useful to write in exam. First, laboratory investigation, then imaging. Laboratory means LFT and CBC. CBC leukocytosis and LFT all will be increased, like features of biliary obstruction. And in imaging, there will be ultrasonogram, CT scan, MRCP. These three. Ultrasonogram, there may be stone, mainly left side is stone, then gallbladder stone, intrahepatic stone. Features of cholecystitis, calculus or acalculus may be found. Dilatation of the bile duct. Central bile duct dilated disproportionately with abrupt tapering and attenuation of peripheral duct liver. This line is written in the Sleisenger. Central bile duct dilated disproportionately with abrupt tapering and attenuation of peripheral duct in liver. So ultrasonogram, we found all the findings, stone findings in the liver, in the gallbladder, cholecystitis findings, dilatation of the bile duct findings. CT scan, what will CT scan showing? CT scan showing delineate complete segmental anatomy. What CT scan show? It shows complete segmental anatomy, segmental atrophy, cholangiocarcinoma. The CT scan figure is shown in the next page. This one, you see, this is a Sleisenger picture. CT in a patient with history of recurrent pyogenic cholangitis, severe right-sided intrahepatic biliary dilatation with interrectal calculi. Dilatation and also interrectal calculi is present. So CT scan showing dilatation interrectal calculi. MRCP. MRCP is the preferred diagnostic test. MRCP, in MRCP we can see focal dilatation, stricture, interductal stone, all the characteristics of the RPC we can found in MRCP. And direct cholangiography or cholangiogram, but it is less suitable than MRCP. Diagnosis of parasitic infection. In CT scan, cholangiocarcinoma is can be also we can found. And about cholangiocarcinoma, there is some lines written in Sleisenger. Cholangiocarcinoma tended to be located in the atrophic segments associated with biliary calculi and was often accompanied by portal vein occlusion or narrowing. So, in which patient there is atrophic segments and biliary calculi, there the chance of cholangiocarcinoma is more, which is often accompanied by portal vein occlusion or narrowing. So diagnosis of parasitic infection, this is laboratory, this is imaging. Now diagnosis of parasitic infection. Which parasite? Clonorchis, Opisthochis. In stool routine examination, eggs may be found. In the Sleisenger there is written the eggs will be found after 4 weeks of infection. Also we can take duodenal and biliary fluid by endoscopy, and egg or intact worms may be found. And in blood test there may be peripheral stiffness, serum Ig level will be increased. So this should not be read more. You can just read this investigation page. Now the coming to treatment. I prefer this page. The first one is antibiotic therapy. If cultures of blood or bile is positive for bacteria, or parasitic infection, if you suspect, then antihelminthic agent like praziquantel 75 mg per kg in 3 divided doses for 1 day. So antibiotic therapy and parasitic infection. Later, evidence of cholangitis or dilated intra and extrahepatic bile ducts may be found in cases of ERCP. In patients with evidence of cholangitis and dilated intra and extrahepatic bile ducts, ERCP is the preferred interventional procedure. So the next treatment is ERCP. If you find dilatation or cholangitis feature in MRCP, then ERCP is the preferred interventional treatment. ERCP with sphincterotomy with or without placement of nasobiliary drain or percutaneous biliary drainage may be required to remove biliary duct stones and traverse strictures. Therapeutic ERCP was particularly effective in patients with disease involving the extrahepatic bile ducts. So if the extrahepatic bile duct more involved, then therapeutic ERCP is the more preferable choice. Another option of treatment is surgery. Hepaticoduodenostomy is the most common procedure. Laparoscopic biliary bypass surgery is also proposing segmental lobar resection, liver transplantation. And there are some complications like recurrent cholangitis, secondary biliary cirrhosis, cholangiocarcinoma, and liver abscess. These 4 complications. From the hand note, I have found this Corvoiser's law. If the gallbladder is palpable, the jaundice is unlikely to be caused by the biliary obstruction due to gallstone, probably because of chronically inflamed and stone-containing gallbladder cannot be readily dilated. And another page I have added the hallmark features of the recurrent pyogenic cholangitis. The hallmark features. This I have already told: stone formation in the intra and extrahepatic bile duct, structure development, biliary dilatation. I have already told these 3 points in the definition. Here the CT scan non-contrast images may be helpful to identify non-calcified pigment stones that are soft tissue density, and use of contrast allows better detection of complications such as cholangitis with improved visualization of ductal wall and periductal enhancement, indicating active infection or inflammation. Here in the picture, this one is pre-contrast. A. This A is pre-contrast. Pre-contrast CT scan shows stones in dilated intrahepatic ducts. But after contrast, B, after contrast, this contrast administration of contrast material, stones are less conspicuous. Here is the another picture for recurrent pyogenic cholangitis, but I think I don't know it. You should not, or I should not read this, because more the exam will knocking at the door, the less you have to get less time to read or revision. So thank you.